We are live now.
So, very good morning to all. Uh, so, what we are going to do today is we are going to talk about theory of insulin therapy in type 1 diabetes. Basically, this session we should be able to answer as to how is it, what are the basic principles of developing an insulin therapy for any child with type 1 diabetes. Uh, It seems very simple, but unless we understand the very basics of why do we things and what are the things to be done and why do we do them, then generally it leads to all those questions regarding can we use premix and what are the other solutions and how do we uh, uh, decide a dose in a particular child. So to go through that, all those intricacies, we have Dr. Vineet Surana with us. Dr. Vineet Surana is a very dear friend. He's done his MD pediatrics from prestigious Maulana Azad Medical College, followed by DM endocrinology from AIMS. He has an extensive experience in treating children with type 1 diabetes, and he's going to take us through this journey. And if time permits, I would request Dr. Vineet also to share some uh, practical aspects of insulin use, but only if time permits. Over to you, Dr. Vineet.
Thank you so much, Dr. Rajiv. And thank you, Team IAP Delhi, uh, who came along with the team speed and formulated this program for the major benefits of children of type 1 diabetes, because we all know the first line of contact with type 1 diabetes children are usually our pediatrician colleagues, who first see them as a case of the decay. And there has been a talk with Dr. Tandon and Dr. Samir Agrawal in the last two sessions, where both have extensively discussed how initial just monitoring of a one blood glucose can lead to the diagnosis of decay in the children who are just coming with the symptoms of the vomiting and the pain abdomen, which hardly cost them the 60-70 rupees of one testing in the hospital also. And but then that can be life-changing moment for them. So it's important that what we have discussed till now, I'll just share my slide. Just a moment. Just please confirm if it is full screen.
Uh, it is not full screen yet.
Okay, just a moment.
Perfect, perfect.
Yeah. So, think just, yeah. Okay. Yeah, so till now we have discussed about the type of the diabetes, what is the prevalence and incidence of the diabetes in the young children, and how important it is to diagnose them the early stage. So before I go towards the insulin management in children with the diabetes, what we need to understand is that diagnosis remains very, very important. Last session, Dr. Samir has extensively showed some case snippets where he has shown that how the children who were thought of the type 1 diabetes turned out to be the something else, and the children who were thought of that some other diabetes turned out to be the type 1 diabetes. And then what we need to understand is type 2 diabetes, especially in the city, has not remained uncommon nowadays. The youngest patient which I am seeing with type 2 diabetes is the 13 years of age, the age which probably a decade back I would have even never imagined that we can see the type 2 diabetes at 13 years of age. If someone even tell that this is type 2 diabetes, we will just laugh and say, how can you diagnose type 2 diabetes at this age? But now that's the reality. And as Dr. Tandon had already discussed in this first session, that type 2 diabetes being much more aggressive in terms of the complication. So we are diagnosing one diabetes which can be immediately life-threatening. That's type 1 diabetes, where the child is presenting with the diabetic ketoacidosis. And another hand, we are diagnosing a type 2 diabetes, which though rare but rapidly increasing, can lead to long-term complications coming very, very early. So both require a different approach, but ultimately both of them, I mean, type 1 diabetes will require insulin from the start itself, and type 2 diabetes usually require a early insulinization compared to the adult onset type 2 diabetes. So let's discuss what is the insulin, what are their theory and the practice. So before I go towards all this, I'll just take you through some 2 or 3 cases where we see that how how we can apply this theory which I'm going to discuss today in a practical world scenario. So this is a 4-year-old child who was admitted with DK few days back and has now been discharged on the insulin therapy. Now the child has come, and the challenge in front of you is how do you plan insulin therapy for this child? How would we know if the child has entered the honeymoon phase partially or completely? And then we need to make a list of all the issues that parents might have and need to be discussed with them. Now, the second case is 10-year-old, well-established type 1 diabetes for last 6 years. He presents to us with an A1C, which is 10.2%. He is already on a premix insulin twice daily, has no blood glucose log, and take insulin as per the food based on his own experience. Now, here the question comes, how again the plan the insulin therapy for this child? Now, who should own the responsibility of the care, whether it is the parents or the child who would take the responsibility of his own care, and who should inject the insulin? And secondly, we need to make again the list of all issues that need to be discussed with the parent and child. Now, this is another case where the 22-year-old young girl comes to us with the type 1 diabetes for last 12 years. He presents to us with an A1C of 9.2%, already on a basal bolus regime, which is the ideal regime. She does a regular blood glucose testing, but maintains no charts. So there's no idea how it's going. And they take insulin as per the food based on the experience. Again, the challenge comes how to plan the insulin therapy for this child. How would you motivate this person to achieve good glycemic control, which is very, very important, and then again make a list of all the issues. So before we come to the answer of these questions, we need to understand what is the insulin, how does it act, so the basic physiology of the insulin, and then what is the difference between a natural insulin, which is being secreted from the pancreas, compared to the insulin which we inject in the subcutaneous tissue. So whenever we eat food, there is a complex carbs which gets converted into the simple carbs in the gut, and then it's the blood glucose which goes inside the bloodstream, and from there it has to go to the cell glucose. Now there are certain cells which are insulin dependent, especially the muscle, fat, and liver cells, which requires the insulin as a key for glucose to enter into the cell. If insulin is not there, then glucose start getting accumulated in the bloodstream, and then these cells ultimately will require some amount of energy to sustain themselves, and then it start burning the fat more and more, and in that process they generate lots of ketone, and finally the child ends up with the ketoacidosis. So what happens? Insulin comes and attach with this receptor, and then there are GLUT4 which goes and attach to the surface of the cell, and then glucose gets entry into the cell. So this is the basic physiological mechanism which happens in all the persons with an insulin sensitive tissues. Now, but this mechanism is actually lost in type 1 diabetes because the basic insulin is not there. So there is a two kind of mechanisms which happens in controlling the blood glucose in a normal human physiology. So there is some amount of basal insulin, and then you call it prandial insulin. So what happens? Now, this is the blood glucose level which is consistent. Even if we fast for a 24-hour, it doesn't happen that we go into the hypoglycemia immediately. We maintain our blood glucose level up to a certain extent. And so what happened with that? I mean, so there is some amount of basal insulin which is being secreted from the pancreas to maintain that blood glucose level at the optimum level. So we don't end up into the hyperglycemia nor into the hyperglycemia. So it's basically the game of insulin plus glucagon which maintains the blood glucose level, and then this basal insulin makes our glucose remain stable. So some amount of insulin is something which is needed by our body, even in a fasting state. Therefore, that is called as a basal insulin. Now, basal insulin is taken largely as once or twice a day injection. So nowadays, mostly when we are using something like an glycine or degludec, that is once a day injection. Whereas there are older insulin like NPH, which is usually taken as a twice a day injection. So the example of this basal insulin is glargine, NPH, and degludec, as I discussed. So ideally, basal insulin is something which should never be missed, because once we miss so even if the child missed the food, missed their prandial insulin, but if they have taken the basal insulin, then chances of going into diabetic ketoacidosis remain less. Now, what happens to the mealtime insulin? So we have the food. So this is the blood glucose. Yep. So this is the blood glucose which is rising as someone has the food, and then by 4 hours, our blood glucose level come back to the baseline. So this is the standard physiology which happens in all of us. So as soon as we eat, our blood glucose start rising, and then it goes to the peak by almost 2 hours, and then it comes down to again the baseline by 4 hours. Now, sorry. So with that, what happens? So there is a insulin secretion also. So as soon as the food goes inside the gut, our pancreas starts secreting the insulin to digest that glucose, and then it brings down the blood glucose level to the baseline. In that same process, insulin also comes back to the baseline value. So again, it goes to the basal state. Now, so whenever we'll have the food, so it will change. Now, in the people with diabetes, what we need to understand is that we have a food, it causes rise in the blood glucose, insulin being secreted from the body, and then blood glucose come back to the baseline by 4 hours. Now, in type 1 diabetes or anyone who is dependent on the insulin, what happens? We don't secrete the insulin as per the food. Actually, we first take the insulin, then take the food, and then there is a change in the blood glucose. So basically, there is a basic mismatch in the normal physiology in the type 1 diabetes, how we're treating, compared to the patients who don't have the diabetes. So in type 1 diabetes, basically, it is the insulin is being given, then the child takes the food, and then there is an alteration in the blood glucose. So what happens in that process? If there is a food discordance, like same dose of insulin we have given, we suppose, for example, we have given a 6 unit of the regular insulin, and the child who is okay with that 6 unit with a 1 chapati and the vegetable, and then suddenly he feels, no, that today's vegetable is very good, I want to have 1 more chapati, then this is what the exact response we will get. So your blood glucose will go higher, and it will again take the time to settle down to the baseline. So basically your baseline goes up. So it should have come back to the baseline, but it doesn't come because your insulin remains less compared to that amount of food. And in that process, your blood glucose remains up and your baseline changes to the higher side. Now, what happens if we take a less food? So today the food is not very good and I don't want to take that much food. So what I do, rather than taking 2 chapati as a regular, I want to take only 1 chapati, but I have taken the same amount of insulin. Then what will happen? So this is typical response. Sorry. You will see that child has led up into the hypoglycemia because we have given a fixed dose of the insulin, and now the child has taken less food. And this actually is very, very common, especially in a younger children who are less than 10 years of age, or rather you would call it less than 5 to 7 years of age, where there is a no fixed meal pattern possible because child may feel hungry anytime, child may eat less food, they can be food fussy, so they can have a more food sometime, and then you will see these kind of the fluctuation happening very, very common in younger children. So now when we look at this equilibrium, what we see, so whenever the blood glucose rise, there is an insulin going up, and then again coming back to the baseline. So suppose this is breakfast, this is our lunch, and we don't forget the snack time. So evening snacking is something which is very, very common, especially in our country. We take a lunch and then evening we eat something, and then again in the night we have a dinner, which is usually the late night. So this evening snacking actually also causes a spike in the blood glucose. So there are two instances where you see the blood glucose management of blood glucose becomes really difficult, especially in a school going child. That once they come back from the school, you will find that pre-lunch value is very, very high, and you do all kind of permutation combination, but you find it difficult to control that level. And similarly, when you look at the evening time before the child goes for the play, they eat something, the mother will always give them some amount of food, and then they go for the play, and when they come back you will see the blood glucose is already at a very high level. So we should not forget the snack. That is very important. So if there is a snack which contains a carbs which requires more than 1 unit of insulin, probably you need to inject the insulin there. As similar scenarios in the school also, sometimes the child don't have a much of the breakfast in the morning because they are always in a hurry. They'll eat hardly something. The parents will give a half a dose of insulin, and then in the school he will go and have the royally one or two paratha with the sabji, and then you will say by the time they come back, so there is only option remains that they might have to inject the insulin in the school. So there are certain children whom I am seeing, they inject their insulin in the school. So what happens? They talk with their teachers, they talk with their nurse who are appointed to the schools, and then they make a kind of arrangement where the child can be given insulin in the school also. And nowadays more and more school have started accepting this fact that yes, type 1 diabetes is there, child may require insulin, child may require food during the classes, and we always write a letter to the school administration that the child should be allowed since he or she is a type 1 diabetes, and then usually accept it. Yes, we do face sometimes the problem, but most of the school nowadays are kind of accepting it. So now the problem statement in front of us is we need to match the insulin with food at a given meal or snack. Now, what are the options? Either we fix the food and reach the insulin dose by hit and trial. So, okay, we'll give you only 2 chapati or one small bowl of rice in your meal, and with that some dal and the vegetable and all that. And then we'll keep changing the insulin doses and see where it fits to the perfect. So this is one option. Can be okay in a little bigger children, somewhere who are into the puberty plus, I would call it somewhere around 15, 16, 18 years of age, 20 years of age. But to a younger children, somewhere who are like 5 years, 6 years of age, it becomes really difficult to do fix the food and reach the insulin dose by hit and trial. Now, what is the second option? Second option is change the dose of insulin as per the quantity of food which is given, or use the food exchange. So that means we know that this much quantity causes this much rise, and then we change the dose of insulin and we use the food exchange for the same. So suppose, for example, one roti and sabji needs 2x unit insulin, and then each subsequent chapati will require additional x unit of insulin. So suppose if the child says, no, I want to eat little more today, I'm feeling more hungry, and if he wants to have rather than 2 but 3 chapati, then probably you will add the additional x unit of insulin at that point. And then you can have a food exchange also, like one chapati is equal to one bread piece, like one katori of rice and 25 gram of pasta. So this is a standard food exchange which can be taught to the parents, and that can be used. Now, the best option remains the change the dose of insulin as per the quantity of carbohydrate in meal. So this is a little technical challenging, but I will not call it too much also. But then, so the parent has to be little educated to understand the carbs counting, and if they are able to do it, this is the best way to manage the blood glucose. But that doesn't mean that child can eat whatever they want. Yes, they can do the carb counting, they can eat, the amount can be changed, but the quality of food, if there is a too much of the junk food, definitely there will be again the fluctuations in the blood glucose because your glycemic index changes very fast. If you give a very simple carbs, then it becomes difficult even with the carb counting to maintain the blood glucose. So for example, one roti is equal to 25 grams of carb. And if you do the exchange, so one small katori of rice is also equal to 25 grams of carb. So this food exchange, one chapati is equal to one small katori of rice is taken from this. Now, how to understand to know the dose that this much quantity of carbs will require this much amount of the insulin. So this is not fixed. So someone can require at the 15 gram carb, 1 unit of insulin. Someone can require 10 at the 10 gram of carb, 1 unit of insulin, and some may require even a 30 gram of the carb, 1 unit of insulin. Now, how do we decide that? That's it called insulin carbs ratio. That means the X unit of carbs for X unit of insulin for X gram of carbs. Now, so I'll come back to this later, and there is a also dedicated session on this towards the carb counting, which I believe is going to happen after next to next, where we'll again come back to this carb counting. Now, what we need to understand is the basics of the insulin. Now, pancreas produce only one type of insulin, and that is known as the human insulin regular, which contains the alpha chain and the beta chain. Now, what happened? A regular insulin is something which have as a standard. Now, so whenever this regular insulin remains as a basal dose, and then whenever I am eating the food, this regular insulin increase its concentration. So pancreas gives a more insulin into the system, and that brings down my blood glucose back to the normal post-meal. Now this is something which can be almost mimicked by the insulin pump, where also we set the basal doses in the insulin pump, and then we teach the child and the parents to give the bolus doses whenever the child eat based on the carbs counting. And that's how it can be kind of mimic something like a pancreas, where there is a increased concentration of the same regular insulin brings down the blood glucose to the normal. Now, however, when we are giving the subcutaneous injections, so it is not possible. So there is a two kind of things which can be done. One, there is a faster association, what we are talking about, which leads to the rapid insulin. So they are given into the subcutaneous tissue, have a rapid dissociation from their combination, and then it gives a very rapid insulin into the bloodstream. Whereas there is a slower dissociation which remains in the subcutaneous tissue for prolonged time, and there is a slower dissociation of insulin molecule from their combination. So these are basically the longer acting insulin. So just for an example, if I take this as a picture, so this is a IDES ASP in formulation. So basically this is a two kind of insulin which is given in a one combination. So something like you have a 25% as a aspart and 75% as a degludec. Now, once it's given as a subcutaneous tissue, they both go separately. So they don't remain in a combination. They both go separately. Now the aspart one gets rapidly dissociated and takes care of the meal which was taken at that point of the time. And then this degludec remains in the subcutaneous tissue for a very longer time. It gets very slowly dissociated and works for almost 36 to 42 hours to take care of the basal insulin requirement. So this is the available insulin what we talk about. So we have these 1, 2, 3, 4, 5 insulin are, which is the faster acting insulin, rapid insulin, and these are the one which is a slower or longer acting insulin. So regular insulin is something which is the standard regular insulin which we use. Then there is something called faster acting insulin as part, which have an immediate onset. And nowadays says that this faster acting insulin as part and even the uh, so these can be even given post meal, also immediately post meal. So what they say that it's a kind of can mimic something like a natural course what is being happened from the pancreas, and here the child have the food, we know how much food he has taken, and accordingly we give them the insulin immediately post meal. So the faster acting insulin as part has that advantage, which start having the work within the 5 minutes, and it just goes off in 3 to 4 hours. Similarly, then we have an insulin Lispro and Aspart, which requires an onset in for 15 minutes. Then we have an insulin Glulicin, almost similar. So Lispro, Aspart, and Glulicin are almost similar, but from a different company. Now, then we have a longer acting one, something like an NPH, which is the oldest longer acting one. So it has got like it's onset by 1 to 2 hours. It works for around 12 to 14 hours. And some the problem with the NPH is it is again the peak insulin. So it gets its peak by 4 to 10 hours, which is very, very variable. And then it starts so it's finished, it works by 14 hours. And then we have a detimir, which is mostly nowadays we don't use too much. We use mostly in the pregnancy. And nowadays when the degludec is also approved for the pregnancy, most likely detimir is most likely it will go off the shelf. Then we have a glargine, and then we have a degludec. So glargine works for almost 16 to 24 hours, and the degludec works for almost 42 hours. And there is another insulin, which is just a concentrated form of the glargine, that is 300 IU per ml, where they say that it works for almost 24 hours, which glargine was not able to meet in each and every patient. So basically what we need to understand is we have a two kind of insulin available with us. One, which can be taken with the meal. So these are all the rapid insulin, and the another one which act as a basal, usually taken once a day, and can be act as a longer acting insulin. So this is the typical insulin profile for all. So endogenous non-diabetic, this is what happens. You eat food, your relative insulin effect comes fast, and then it goes down fast within 2 hours. However, the different insulin which we use, something like a rapid acting insulin and then the longer acting insulin, have a different profiles. Now, coming to the basics, how to start the insulin therapy. Now, so there are certain calculation which we need to understand before we take into account that. So it's not something a random shot. Okay, you give them 10 unit in the night as a basal, 4 unit during the daytime as a meal insulin. No, it's based on complete scientific this one. So total insulin replacement requirement comes around 0.8 to 1 units per kg per day. So there are exceptions to this, which I'll come in the next 2 slides. So out of this, half you consider as a basal and half you consider as a prandial insulin. So suppose someone who's requiring a 20 units of insulin per day. So you will consider that 10 you will give as a basal unit and 10 you will give as a prandial unit, which you usually initially divide into the 3 equal doses. Now, so there are two other calculation which you need to understand: insulin carb ratio and insulin sensitivity factor. Now, there is a no fixed ratio, as I said earlier also. So starting point can be something like we are 500 divided by total daily dose. So someone who has got a 50 units per day, there what you will do, 500 divided by 50 units means for each 10 gram of the carb, he will require 1 unit of insulin. So this is important for us to understand. So someone who has got a 50 units for each 10 gram will require 1 unit. Now someone who has got a 10 units total daily requirement, which can happen in the younger children. So for them, every 50 grams of carb will require 1 unit of insulin. So, but remember, this is not a fixed number. These numbers changes as the age of the child change. Second, this number also changes during the daytime also. So someone can have a higher insulin carb ratio during the breakfast time, and someone can have a higher insulin carb ratio during the night meal time. So this is just a starting point that to start with, you can calculate the insulin carb ratio based on this. And then you need to kind of fine tune based on your blood glucose log that how the response of insulin in coming to the uh, carbs given. So then the second one is insulin sensitivity factor. It is nothing but what we say is that how much we expect a reduction in blood glucose value after administration of 1 unit of insulin. So again, this is not a fix. So in some patients it can goes down to with 1 unit you can bring down by almost 100, and in some it can come down to only the 20. So it's depend upon what is their total daily dose. So starting points remain somewhere around 1500 divided by total daily dose. So someone who has got a 50 daily dose, so for every 30, so 1 unit of insulin will bring down their blood glucose by 30 units. So this is important for us to understand. Now, the most important part which we need to understand is before we go into that start doing everything correct. So this is sometimes lead to a lot of mess. First, thing is set the bolus first. And this is very, very old dictum. It says you first correct the basal, correct the fasting, and then you will find that rest of the things becomes little easier to correct. So how do we set the basal dose first? Now, it depends upon the what insulin we are using. So suppose if you are using glargine or degludec, then we ask the child to take an early dinner. So maybe by 6 p.m. So this is by 6 p.m. we give the early dinner, and by 10 p.m. In the blood glucose come back to the baseline level. So it takes around 4 hours, as we discussed in the last slides, that blood glucose will come back to the basal level. Now, suppose if this basal level comes out to be 130, we'll see morning 6 a.m. what is happening. You see it is 130. That means your basal dose, what you gave, was adequate. Because basal means what was there in the night should be same in the morning. Now, suppose my 180 was at the 10 p.m. and in the morning, if we see the 130, what does that mean? That means we are giving a higher basal dose. So suppose the day when this 180 will become 130, this 130 will go down into the hypoglycemic range. So that means to correct that 180, when we give a higher dose of the basal, so that led to the hypoglycemia to the child the day when your post-meal 4-hour blood glucose was 130 or 120. So what we need to understand is, yes, there can be deviation of plus minus 10%, but what we get 4-hour post meal in the night should be same as the morning fasting plus minus 10%. But if there is a lot of dip in the morning compared to what was in the night, that means the moment you correct that level value in the night, the child will end up into the either midnight or the early morning hypoglycemia. So this is wrong. So when you see the 180 in the night, you will see that 180 in the morning will tell that yes, your basal dose is correct. You take care of your prandial, this 180 will come back to the 130. Now, what about the NPH? NPH, since it requires 2 injections in a day, so you can't do in a one go. So first you do the overnight test and then set the morning basal first. Then you do the first half day test because you can't keep the child hungry whole day. And then you see that what happens to so you skip these 2 meals and then see what happens in the next 6 to 8 hours. And then again, you do the evening one where you skip the snacks and this, and then you see what happens in the evening hours. So that's how you set the basal for the NPH also. Now in the pump, it becomes very easy. You just keep skipping 1 meal at a time and see the performance of basal rate across that time period. Now the beauty of the pump is you can set a lot of basal rates actually. So your basal rate may be different between the morning 4 to 6 a.m. It can be different between 6 to 12 p.m. And then it can be different from 12 p.m. in the afternoon to the midnight into the 12 a.m. And then you can set all this basal rate by skipping 1 meal at a time and see the performance of basal rate across that time period. So what are the advantages when we set the basals? One, it does is it allows the flexibility for the meal times. Now, so what happens? If your basal is fixed, if your blood glucose remains same, so it is not that I have to have my breakfast by 8 a.m. My blood glucose is fine with that basal insulin. I can have my breakfast even at the 10 a.m. and then I need to take that mealtime dose and then my blood glucose should remain okay. So that allows the flexibility for the mealtime as a one. Second, makes building pre-meal dose relatively easy because your basal is fine. So every time you will find that it is 120, 130, 110, something like this. And then based on that, you have to just do the carbs counting and change the prandial doses and make a pre-meal dose easily in a correction dose. So, and then there is a lower risk of the hypoglycemia if your basal is correct. Now, how to set the pre-meal mealtime insulin dose? So ideally, pre-meal value should be in the acceptable range before you go for the prandial insulin dose. So your basal should, as I said, basal should be corrected first. Now, set a dose with target blood glucose value. So either at pre-meal blood glucose value plus 40 to 60 milligram per deciliter if you're looking at the 2-hour post-meal. So this is what the expected rise you see, that whenever we eat, our blood glucose go by 40 to 60 points up after 2 hours, or We take a pre-meal plus minus 10% at 4 hours, provided there is a no snacking in intervening period. So it's possible for a little elder child, but for a younger, very young child, making them hungry for 4 hours sometimes become really difficult. So the starting point again in this is total pre-meal dose we decide divided by 2 will give me the prandial dose. Now this dose at each meal is divided into, so X is my, so suppose I have a total of 30 units per day. I divide it to the 2, so 15 goes to the basal. Now 15 comes to the prandial dose. Now 15 we divide into the 3 equal dose, so 5 units at each meal, breakfast, lunch and dinner. Now we need to fine tune it gradually by 10% quantum. This 10% quantum doesn't mean that we are doing it on a daily basis. Let the insulin get settled down. So you can ask the child to change it on every second or the third day to fix these doses. And then if the carbs counting is not possible, then fix the food first, and then you need to fix the insulin. The best way is to do it by the carbs counting. So calculate carbs in the meal. Then you need to know your ICR, insulin carbs ratio. So obviously, initially you will not be knowing your insulin carb ratio. So start with a 500 divided by total daily dose. So that will give you your insulin carb ratio. So that means for every 10 gram or 15 gram or whatever your insulin carb ratio comes. So and every X gram of the carbs, you will require the X unit of insulin, Y unit of insulin. And then based on that, insulin to cover meal would be carbs divided by the ICR. So suppose if my carb ratio is somewhere around 10 and I'm taking 50 grams of the carbs, so then I will require around 5 units of insulin. And then we need to fine tune as per the response depending upon, and then slowly over the next 2 to 3 months, parents and the child both know that what is their ICR during the breakfast time, what is their ICR during the lunch time, what is their ICR during the dinner time, and accordingly it can be fine tuned. So start with equal ICR at each meal and later on it keeps changing. And then total daily dose, when we put it in the to calculate ICR, depends upon what is the dose which the child is taking currently. It can be either 0.8 per kg per day or current TDD, whichever is lower. So if my total daily dose is less than 0.8 kg per 0.8 per kg per day, then probably I'll go with that dose and calculate my ICR with that. Now, concept of correction dose. So this is one, and then this is insulin sensitivity factor, which we calculate based on 1500 to 1800 divided by total daily dose, which is a kind of good starting point. So if we find the total daily dose is 50 units, 1 unit of insulin will bring down blood glucose by 30 to 35 points. So suppose if you find the pre-meal blood glucose is 240, so that means my target was to keep somewhere around 130. It has gone almost like 110 up. Then we'll give you around, from the 30-35 if we calculate, a child will require extra 3 units would be needed as a correction dose. So, but remember, all these are initial starting points, and then you need to kind of actively involve the child and the parents, and then we need to find out what is his own insulin sensitivity factor, what is his own ICR, and based on that you find down. So yes, it looks a little, I mean, a kind of cumbersome job, but actually if you start doing this, what you will find in next 2 to 3 months, the child gets very much accustomed to this, and they know by heart that what is their ICR, what is their ICF, and then based on that, they look at the food and tell, okay, this will have this much of the carbs, and then this much insulin I will take. And most of the time, they come out as a correct dose. So pre-meal bolus now is being decided by dose required to cover the meal plus correction dose. For example, if my pre-meal blood glucose is 130, mealtime dose is 6 unit, which is decided based on the ICR. Now the bolus dose required would be 6 unit plus 0 unit. So that's the 6 unit. Now, in a person who has a 50 units total daily dose, pre-meal blood glucose comes 230. Now the mealtime dose becomes 6 unit plus bolus dose required would be 6 plus 3. That 3 is your correction dose. So total 9 units he will be taking. So that's how you correct the complete thing. And the lastly, which I would definitely like to emphasize again, that cover the snacks. So most of the time we forget to cover the snacks. So ideally, any food which is requiring more than 1 unit should be covered with the pre-meal insulin bolus. So sometimes it's become necessary to give one extra shot at the snack time or in the school to take care of that rise in the blood glucose. Now, I have discussed all this extensively. Now, before we apply this, we need to understand where should we apply this. At a diagnosis, can we apply these rules of ICF, ICR, and the total daily dose? The answer remains no, because your requirement remains very, very high at that point of the time. And if you start applying these rules, your blood glucose controls becomes really bad. But then what we need to also understand is the child who is landing up with the decay, your job is to control his decay, bring him out of the decay. Don't try to control the blood glucose too much because it will take some time. So what happened in that process? We keep increasing the dose. Oh, still it is 300, it is 400, it is 250, it is 200, and we are not able to achieve in the next 2-3 days the normal blood glucose control. So that's not possible actually. We need to discharge the child, send them home, let them settle down. We need to teach them the basics to how to take care of the hypoglycemia, what food to be eat, what not to eat, and then kind of let them kind of get to accustomed to the disease which they have got. Call them in the 2-3 weeks. By that time, that glucotoxicity part will be going off, and then the child will start having a better glucose with the same units of the insulin at which you have discharged the child. So it takes time for the body also to get adjusted. So and that's why and then initially when there is a glucose toxicity, there will be complete shutdown of the pancreas moment we bring them out of the decay, and then there will be some amount of insulin still secretion start happening, and with the same dose what you were giving there will be better control. And if you keep increasing dose, then child ends into the severe hypoglycemia sometimes, and that becomes another problem. The one time I was admitted with the decay, and the next time I'm admitted with the severe hypoglycemia. So this is something which we should avoid. Now, can we use these rules in the honeymoon period? The answer is absolutely no, because your requirement becomes very, very low in the honeymoon period and it remains very variable. So these rules doesn't apply in the honeymoon period. After once the honeymoon period is over, so that honeymoon periods usually can last from 2 months to even up to the 2 years in a child. And then during that time, your requirement will be low. But once the honeymoon phase is over, when the child is into the frank type 1 diabetes now, then these rules will apply very, very nicely and you will get a better control of the blood glucose with this. Then another important part is, as I said, the hypoglycemia is something which we should treat first, and we should avoid the hypoglycemia as much as possible, because it is not possible to treat hyperglycemia without causing harm if hypoglycemia is not tackled first. So because the child goes into that hyper roller coaster, he goes into the hypo, body react to that, then again there will be high blood glucose, again you will react to that, there will be hypo, and this roller coaster needs to be avoided. So go slow, give some time to the child, and you'll get a better glucose. And then again, lastly, treat the patterns. We don't treat the individual value. One value is 240 and another is 90. Then we don't act based on each and every values. We usually treat the patterns like something like this is the fasting of 90, 180, 140, and 240. So outlier is something which probably will not look at. We'll look at the patterns. Similarly, in the before lunch, then before dinner. So if you look at this, you will find, if you look at closely these values, what you will find is, if my fasting is fine, my daytime blood glucose is also coming better. But if my fasting is bad, then you will see that my daytime is increasing. Same way here again on the day 3, if you see my fasting is okay, I mean, not that okay, but this is still better than 180, then my blood glucose is slightly better, but not as good as the day 1. And if my fasting is worse than my whole day, so that means the problem is with the fasting blood glucose. Your basal is not yet set the basal, and probably your all will fall into the range. So coming back to our case scenario. Now, this 4-year-old child who was admitted with the decay a few days back, when he's being discharged on the insulin therapy, as we have discussed till now, we know that the plan for insulin therapy will be basal and bolus. And then based on their requirement, somewhere around we discharge them on the basal bolus regime depending upon the total daily dose requirement. So usually once the child comes out of the DK, you see them what is there in the ward, how much is their total daily dose requirement. Based on that, you divide them and then send them on a insulin basal and bolus therapy. Uh, and then the second question comes, yes, once the DK part is getting over, when there is a 1 month or 2 month post DK, the child will enter into the honeymoon phase. How will we know that honeymoon phase has come? The same unit of insulin, which was being adequate, now causing the hypoglycemia, has started causing hypoglycemia in the child. That means that child has gone into the honeymoon phase. Now it's become really tricky to treat the honeymoon phase. What happens? The everyone thinks that honeymoon phase has come, that my child has recovered from the type 1 diabetes. What doctor were telling that he will require lifelong insulin. Actually, his insulin requirement is not at all there. Then probably my child has come out of the honeymoon phase. This is the time when you have to be with the parents and tell them, no, the child has gone into the honeymoon phase. It will take some time. And because my pancreas has started working a little bit again, and then once this gets over, honeymoon phase, maybe it maybe last for 2 months or to 2 years, and then the child will again require the full phase basal bolus regime. During the honeymoon phase, sometime even they may be very well managed with a single basal dose also. So this requires a very much individualized care and depends upon how the child's honeymoon phase is behaving. Based on that, we actually adjust the doses. Then coming to the second one, here the child is already on a premix insulin twice daily, and what we have learned till now that giving premix will never match the physiology of the insulin therapy. So premix can be okay in type 2 diabetes where there is still some amount of beta cells are left, but in not in a patients with the type 1 diabetes where they require a complete cover with the insulin from the outside. So they have to be on a basal bolus regime, no question asked. This is something which requires a complete basal bolus therapy, so that the child and child's parent has to be counseled about the complete basal bolus therapy. And by 10 years, when the child has already spent the 6 years of type 1 diabetes, so this becomes a little tricky question that who own the responsibility of the care? Is it the parents or child, or who should inject? So usually all my type 1 diabetes children, usually once they are 10 year post 10 year, they start injecting themselves. But I always tell the parents that make sure that they inject in front of you. So I still give the responsibility of care to the parents, but child can inject the insulin, so they start gaining confidence. So by the time they go into the puberty, uh, they know how to manage themselves. So remains very, very important, because puberty is the time when the child start thinking that they know everything, and we need to give them some amount of independence also. But then it has to be so by 10 years, 11 years of age, the child start injecting, but parents need to observe whether he's injecting it correctly or not. Sometimes they don't inject and tell the parents. So yesterday I just got an admission of a child. She's 12-year-old, and both parents are working, and then there is no one else to take care of the child. And child used to tell the parents that yes, she's taking the insulin, but when she got admitted, she told that I used to skip the insulin doses, and that's how she'll end up into the DK. And this is the third admission with the diabetic ketoacidosis, first in my hospital, where in the last 1 year. So this is really, really shameful on our part, that probably there was something missing in the counseling, or the parents were not able to understand, or the child was not able to understand the importance of taking the insulin and managing the blood glucose. That's in a 1 year in a city like Delhi, they are getting admitted third time with the diabetic ketoacidosis, with the blood HbA1c being the 16%. So this is something which is very, very important, that yes, give the freedom to the child, but parents need to observe during their initial pivotal year, because that's become really important. Now, so for this girl who is 22-year-old, she's already adult, she understands everything. And then with the 12 years of the diabetes, obviously she understand everything about the type 1 diabetes also. That's what we believe. But then you will see that still the HbA1c is 9.2% because though she's testing but not maintaining charts, so she doesn't know what fluctuate her blood glucose. She takes the insulin as per the food. Now, a 22-year one is smart enough to understand the carb counting. So they are the best person to be taken for the carb counting. Teach them the carb counting, teach them how to take insulin, see their sites, see if they are taking the insulin correctly or not. Lot of time we see that the in the adulthood they are coming to us by the age of 18, 20, 21, and then we see that there is a complete insulin hypertrophy of the area where they are injecting. So this is something which never gives a good control. So leads to both the hyper and the hypoglycemia. So site and everything is important. I think there will be a video which will be shared in the group about what are the best site to give insulin and everything. And then this girl definitely require lots of motivation to achieve the good glycemic control. So to summarize, we need to fix the diet first, fix the physical activity, assess their total daily dose. If hypos are present, decrease by 20% straight. So whenever we are increasing the dose, we need to be cautious, but decreasing the dose, we need to be really liberal in cutting down the dose. Set the basal dose as a first time, then set the mealtime dose. Do not forget the snacks, which sometimes causes lots of hyperglycemia. And if there is a hypoglycemia, treat the hypoglycemia part because that's very, very important. It can immediately lead to the catastrophe in the child. So thank you. And I think we can take some questions.
Yeah, I think that was that was an extensive and a great coverage on basics of insulin therapy. Just for knowledge of everybody, the practical aspects of insulin injection, we have requested another faculty to prepare a video which would be shared in the group itself, so we can go ahead and look at that things in that particular video. Now, I think just to summarize in this session, we learned that we need to follow normal human physiology for insulin replacement therapy to be given in children with type 1 diabetes. We understood that the basic uh, problem in type 1 diabetes is to match your insulin dose with the food that anybody is taking. And then there are different ways to do that. We can do it either by fixing the diet and insulin dose, or by carb exchange, or by the carbohydrate counting. Then we set the basal first, and then, as Dr. Vineet tells us, that we need to follow each perennial meal, and then we need to do that. We, of course, do not forget the snacks, and we treat hypoglycemias first. So, Dr. Vineet, just coming back to, because we've had this question in every session. I am just wondering why and where from this concept of premix are we still struggling with, despite kind of we clearly knowing that basal and bolus is the therapy. I'll tell you my thoughts on this. Why are we still on this? What I believe is that perhaps a lot of us have been using premix insulin 2 times in a day during honeymoon period or partial honeymoon period. Because in partial honeymoon period, there is some amount of endogenous insulin which is still being produced. So it is the fine tuning which is done by the body. So we have this perception that premix is very, very successful, or it can control blood glucose values, but only in the honeymoon period. Beyond honeymoon period, because there is no way that because premix has got both rapid acting and the basal one, so there is no way that we can match that premix with the food that we are taking outside our honeymoon period. So then that thing can never seem to be working. So I think from this session it should be amply clear that using premix is never a good idea. And in fact, we encourage people not to use premix even during their honeymoon period, because that sets a bad precedent for the child and for the parents. And then they go on taking that premix and has a resistance of going over to basal bolus therapy later on.
Sudeep
Yeah, I think
wants to
Dr.
say
Deep,
something.
if you want to add something.
Yeah, I fully agree with and endorse what Dr. Rajiv is saying and what Dr. Vineet said. But sometimes we come across people as you so called, in the borderline honeymoon phase or recovery phase, that they are taking premix insulin thrice a day. What is your take? They say that we are having major meals, so I am taking three premix thrice a day, and they're resistant to change. What is your take on this?
Dr. Vineet, please.
Okay. See, yes, I'm so in the honeymoon phase, everything works. Even the basal only works. Even the your premix twice a day, thrice a day will work, or even once a day premix also works. So I have one of my doctor friend whose kid is type 1 diabetes, and they are giving once a day your Rhizodec, that insulin, degludec and aspart combination, and she's doing quite fine for the last 6 months. But yes, you agree with them because you know that they will understand. So anyone who comes to me with a premix, or if even if I am putting them on a premix, on a say that okay, the child is doing very fine, there is a hardly 1 unit requirement in the or total 6 unit requirement in a day. We tell them before, and see, the child is into the honeymoon phase. You can manage it with the premix, but be prepared that on any day this honeymoon phase will go. We don't know when it will go. It will go in a 2 months or 2 years. I don't know, but it will go, that much I know. And then you need to be on a basal bolus regime. There is a no substitute to that. So this is what we tell. And even when you give them the 3 times of the premix, the problem with the premix is you have a fixed combination.
Absolutely.
So it becomes really difficult. Okay, for that matter, you give them the premix in a terms of what we used to give in during our training time, that you give a regular insulin plus NPH as a combination in the morning, regular in the afternoon, plus regular and NPH as a evening. So yes, this is a 3 shot which you are giving. It's a, yes, you can call it as a premix, that regular and NPH you are giving, but they are actually not premix. You are mixing them with a
It's a
dose
split
which
mix.
is
Split
required
mix.
for the breakfast plus daytime your basal insulin, same way dose which is required for the night dose, and plus the nighttime basal insulin. So that is something which is acceptable, but the available market-based preparation of premix insulin is something which is not acceptable.
So I think now we should take some audience questions, and then I have a couple of more questions to clarify, which I'll do after we've seen these audience questions. So somebody is asking, RBS is checked in school, or it is just with intake, it is assumed that the blood glucose is high. So I think the question is that when child comes back home and blood glucose values are high, so how can we interpret those high values? Are we assuming that it is because of food, or do we need to check at school and see something else? It can be something else.
So there can be 2, 3 things actually. One, the child would have eaten something with the friends,
Okay.
which is very,
Okay.
very common. We all know किसी का birthday, so somebody would have had the birthday in the school or some other party or something where the child would have eaten something. Obviously, he's a child, he will get tempted towards those things, which is not covered by the insulin. One.
Right.
Second, otherwise, either the school meal is too heavy, which is not covered by the insulin, which has led to this rise, or
Right.
the morning dose would have been inadequate, which has led to this rise. So what I say now, when the CGMS is available, put them on a 14 days when the school is going on the CGMS. You know all the data, what is happening,
True.
and it becomes actually very easy. So I believe the CGMS is actually for the type 1 diabetes, where it becomes really easy to manage their blood glucose based on the CGMS data.
Yeah, although I think we've got a separate session in how to manage diabetes in school, but I would still like to say that we should definitely encourage people to check themselves at school with CGM or without CGM, because
Yes.
unless we ourselves as physicians believe that this mechanism can be set in the school, so there is a lot of safety at stake for children. Not for hyperglycemia, but I'm really, really concerned about hypoglycemia. If child suffers hypoglycemia and there is no way to check them at school, their blood glucose values at school, then that's really, really a problematic thing. We're not doing optimally for our children. We're not ensuring their safety, let alone the control in the long run. Okay, so the next question is best time to give basal insulin.
Okay. So it depends upon what insulin you are using. If you are using the glargine or the degludec, you can give any time of the day. I mean, so by convention, we give in the night because the child has already taken 3 insulin during the daytime. Okay, bedtime, we will take 1 insulin and we fix the fasting with that actually. NPH has to be taken twice a day. With a one time of NPH, it's really become difficult to control the whole day's basal blood glucose level. So by convention, we give it in the night. But yes, degludec is something which can be taken any time of the day. Same is with the glargine also, that it can be taken any time of the day.
Right, right. So I think the logic for giving glargine in the night largely stays because earlier we know that in few people glargine will not work for 24 hours. It may work
Yes.
only for 18 to 20 hours. So I think idea was that even if your glargine does not work in the evening hours, so you still have a regular insulin which can somehow cover that problem of basal being there. Sometimes glargine is given in the morning if people have early morning hypoglycemia. So sometimes that can be avoided if we shift glargine in the morning. But in large majority of children, it does not matter whether you are giving glargine or degludec in the morning or in the night. We can choose whatever time is convenient for the parents and for the child. Above what glucose levels decay sets in different age groups?
Okay, so actually there is a no level. So we have seen the decay even with the 250 and we have not seen the decay even with the 500. It depends on the multiple factor. So decay is actually not the glucose level, it is the absolute insulin deficiency which leads to the decay. So even with the 250, if there is a no insulin, that will lead to the decay. And even with the 500, if the child, so you will see a lot of type 1 children who is having a consistent 400, 500 values, taking the insulin once or twice a day so that they manage it very well. They don't end up into the decay, but yes, blood glucose control is absolutely pathetic. That is one thing. But they don't end up in the decay, but दिन में एक बार तो इंसुलिन ले लेते हैं basal वाली.
Right, right. I think we need to be clear, although we've got another session which is to be taken by our teacher, Dr. Rajesh Khadgawat, I think in coming times. But we should absolutely understand that the decay is because of lack of insulin, not because of high blood glucose values. High blood glucose values are a surrogate marker of insulin deficiency. So it may correlate, but that is not universally
Absolutely.
true in every instance. Okay. So the next question is, how do we know honeymoon period has ended?
Okay, when the same dose of insulin is leading to the very high glucose value, it's very simple. So same dose of insulin which was leading to the hypoglycemia, and now we are keep increasing the doses of the insulin. You are not able to manage with the only basal or something like a premix. That means the honeymoon phase has ended. The time has come to shift to the basal bolus regime.
Right. Okay. So I think the case that we discussed here, honeymoon, so child presenting with a decay and then coming back to us with and for therapy. I think that's where we need to understand is that uh, at that time, not only the child has insulin secretory deficiency, but there is also an inherent insulin resistance which is there because of the inflammatory milieu of decay has introduced. So the normal requirement during that time may be even higher than what normal physiological requirement is. So we may even require 1.5 to 2 units per kg per day. But the idea is to keep that dose little lower, because if you are giving dose which is more than normal physiological requirement, so even if those beta cells starts working leading to partial honeymoon period, we would never come to know about it. So idea is to maintain adequate amount of insulin in the body so that decay does not happen again. But then perhaps it would be a good idea to keep dose on the lower side and then let blood glucose values solve on their own. So the next question is, sir, can you explain about insulin carb ratio once again?
I think Dr. Rajiv, there is already one session you have put up for the insulin carb ratio, but still, what we need to understand is insulin carb ratio is simply that how much carb will require a unit of insulin. So that means someone who has got an insulin carb ratio of 15 That means, what does that 15 means is that 15 grams of carb will require 1 unit of insulin to maintain your normal glucose value. Now, how you decide that depends upon your total daily dose requirement as a starting point. But remember, this is not a fixed ratio. These ratios keep changing with the age also. During the puberty, it will be totally different compared to when you are in a younger age group. So it's not a fixed ratio. And this is not fixed even during the day also. So your ICR may be totally different in the breakfast time compared to ICR which you are looking at the dinner time. So you start with a simple ICR ratio divide, which you calculate divide by 500 divided by total daily dose, and then you equally divide into 3. But then once you have decided that this is your ICR, then you need to kind of fine tune. So yes, it looks cumbersome. It takes around 2-3 months to come to know what is this particular child's actual ICR. But after that, the life becomes much better for that child who is calculating their carbs and taking insulin based on the ICR.
So, next question is, sir, what is expected range of blood sugar during discharge of DKA patient? So I
I'm
think
sorry.
we need to be very, very brief for this because we've got a separate session on this.
Sorry, I didn't get the question. Your voice broke.
Expected range of blood sugar during discharge of DKA.
Okay, during discharge of DK, we are not looking at the blood sugar actually. I don't even look at the blood sugar. If the DK is resolved, child is able to eat. He is able to maintain his day-to-day activities. His DK is completely gone. Then and the child is now, parents are now educated enough to take care of the insulin doses and the blood glucose monitoring at the home. We discharge the child next day itself. So we don't look at the blood glucose value actually.
So the next question is how to know honeymoon period has ended? Do we need to check blood glucose every time before meal?
No, honeymoon period doesn't end in a one meal to second meal. It ends over the days. So you will come to know with the same insulin dose, your blood glucose are increasing. Yes, you need to check the blood glucose even during the honeymoon period. So for every type 1 diabetes, ideally there should be 3 times blood glucose should be checked that what is the blood glucose. And that's very important actually.
Right. Sir, according to you, the basal and bolus ratio should be 1:1. We have read 70:30 or 60:40, slightly confusing.
No. So basal bolus has to be 1:1. What we need to understand is this 30-70 and all that for the type 2 diabetes where they are on a pre-mix insulin, where there is a 30-70 ratio, 50-50 ratio. But in a type 1 diabetes, it is basal bolus to start with is a 1:1. But remember, these are not fixed value. They will keep changing based on the ICR, insulin sensitivity factor, what is their basal dose requirement. So this is just a starting point. What I have discussed today is just a starting point. You have to start with that parameters and then later on you need to fine tune for each and every child. So some child may require almost a 30 units of the prandial and maybe around 15 units of the basal. And some child will require exactly 1:1 of the basal and the bolus.
Right.
Any
Yeah, so
role
these
of
ratios are
peptide
actually
testing?
not fixed.
Sorry, just any role of C-peptide testing in these kids? Will it help?
So I think Dr. Tandon has already taken this class where he told that C-peptide, yes, from the academic point of view, yes, you can do, but somebody who has to pay out of the pocket and who has already landed it with the DK, there is no point of doing the C-peptide.
Yeah. Yeah. So I think just to be clear, these ratios 1:1, 70:30, 60:40 is not a gospel truth for any therapy. We have to start somewhere, and then we can start off with 1:1 if we do not know anything about that child's needs, and then you have to go forward from there. Then it can be 30-70, it can be 60-40, like that. That's an individual thing. That is not a final thing at all. Sir, glargine is better option than NPH as it needs single dose.
Yes, so variability is also less with the glargine because it's a flat profile compared to the NPH. NPH gives a lot of variability because it's not a exactly peakless insulin. But yes, when there is a cost is an issue, we have seen even the managing with the NPH is also, I mean, people have managed with their NPH and the regular insulin also their blood glucose very well.
Right. Yeah. Yeah. So what? Okay. So this I think we've already done. how to diagnose with certainty that this patient is now in honeymoon phase?
As I said again and again, that if your dose goes down significantly with the 2 units of insulin, also child is going into the hypoglycemia. That means he has entered into the honeymoon phase. If you want to
Right.
do more of a certainty, you look at the C-peptide, which will come definitely on a higher side. But I will never recommend to do that because your
Yeah,
clinical experience is good enough to tell that he has gone into the honeymoon phase.
true, true. So I think we took this question last time also. I think there is a lot of fascination around this honeymoon phase. So I think if we have to really objectify it, the way I would objectify it is anybody would require around 0.8 units per kg per day of insulin to manage their type 1 diabetes as a replacement dose. So if you are requiring, which is little lower than this, anything which is around 0.5 unit per kg per day or less than that, then that's a partial honeymoon phase. And if you are able to maintain your all blood glucose values without need for any insulin, so then that's when you are a complete honeymoon phase. Now, how would you know about it? You would only know about it if you proactively start reducing the dose. So what we do in general practice is that whenever type 1 diabetes comes to us and all of his blood sugar values looks perfect after say 2 months of decay, then that's the time, because type 1 by nature has a lot of fluctuations as a baseline. So if you look at a sugar chart, which is absolutely looks, oh, this is an ideal chart, then that means that child has gone into an honeymoon, started going into honeymoon phase, because now body is doing the fine tuning. Then you start reducing the insulin doses proactively, bit by bit by bit, and then you have to see where body supports, on how much lower dose that body support absolutely good sugar values. I think that's the way you practically look at honeymoon phase. So I think we've already answered next two questions. Okay, so how do we monitor in honeymoon phases? Because we've discussed this again and again. There is no fixed rule to monitor during honeymoon phase. We would still say that once in a day, I would say once in a day absolutely should be checked. And any upswing in values should prompt you to check it multiple times more. But testing in between in fasting and post meal state, both of them are good indicator, because few children may have absolutely good fasting values, but their postprandial starts going up because now their body is not able to cope up with the glucose load that they've taken in during their meal. So kind of one fasting and one post meal value may be good enough to monitor during honeymoon phase, and any upswing should kind of prompt us to test it more. Okay. And again, on average, how long does honeymoon phase last in type 1 diabetes?
On average, it is around 6 months, which it
Yes.
lasts.
Right. But we've seen cases in where it lasts for 1.5 to 2 years also.
Yes.
And there are few children in which honeymoon phase never comes, or complete
Yes, that
honeymoon
is
phase
also
never
true,
comes.
actually.
How accurate CGM is? Again, very brief, because we've got a separate session on CGM.
Okay, so if very brief, I would say you need to still check with the blood glucose glucometer at least once a day to see if your CGM is giving a correct reading. Only one line which I would like to add, especially in the summer, your CGM just go haywire. They just give any reading possible on that. In this season, which is the winter, your CGMs are still quite reliable.
Right. So next question is, what mode of insulin is best for newly diagnosed 3-year-old type 1 DM? I think there is only one mode of
Basal
insulin
bolus.
therapy in any child with type 1 diabetes, and answer to that is standard basal bolus. Regular insulin at breakfast with its tailing effect with covered pre-lunch hyper. Please comment.
I'm sorry, I didn't get it. The question.
So regular insulin at breakfast with its tailing effect will cover pre-lunch hyperglycemia. Please comment.
No, it will not cover.
Okay, I think I must give context to this question. I think there is one context where I feel this question answer can be right. Yes. So because I think largely the question that we are asking ourselves is how to manage children in school. So in few children, it can be done this way, but that's not an ideal thing to do at all. What we are trying to do is, because we are not able to convince people at school to support our children with type 1 diabetes, we are looking at suboptimal solutions to be provided to them. And one of them is this: we all of us have kind of used it at some point of time to manage children at school, but this is not an ideal solution to go with. Okay. So I think there is okay. So I think next couple of questions are again on insulin carb ratio. So, and correction factor once given, and somebody is asking to give it with an example. So I think let me take a jab at it. So see, I think from talk, what is clear is that what we need to do is we need to match insulin dose with the food that is being given. When we say food, because diabetes is a problem of carbohydrate metabolism, the other way to say it is that we need to match insulin dose with the carbohydrate that is being taken in each meal. Now, that can be done in a different ways. Either we fix the carb load and then we fix the insulin dose. That also is in a way to calculate a ratio, but then we are not explicitly calculating that ratio. Another way to do this thing is that we fix the carb load at each meal. That I have decided as a nutritionist, as a physician for type 1 diabetes, okay, this child is going to have 80 grams of carbs at lunchtime, for an example. And then I say that, and with gradual calculations, I know that for 80 grams of carbs, this child needs 8 units of insulin. So say, so what the child can do now is that child can do food exchange within those 80 gram carbs, that he still need to fix his lunch at 80 gram carbs. We fix the dose of insulin at 8 units, and then child has to take 80 gram carbs every day. Now he can change that. He can exchange one chapati with one small katori rice, or one piece of bread, or 25 grams of pasta, as we discussed. Another way to do this thing is that we give them this ratio, that for every 10 gram of carbs, you need 1 unit of insulin. Now they are free to take how much carb they want to take at lunch, and then they just have to vary their insulin dose at each meal. So which gives them more independence, but obviously that needs more calculation. Those calculations need to be done on daily basis. So not all patients are able to calculate that insulin carb ratio. So, but that's basically the insulin carb ratio. How 1 unit of insulin would be able to neutralize how many grams of carbs is basically the insulin carb ratio. And the correction factor is, if I give somebody 1 unit of insulin, by how many milligrams would their glucose come down? So that's called a correction factor. So say if I give you 1 gram of insulin, 1 unit of insulin, and your blood glucose comes down by 50 without taking any meal, it has got nothing to do with food that you take. So then your correction factor is 50. So now suppose my pre-meal is 180, which ideally should have been 130, which means that I've got 50 milligrams more glucose in my blood to cover. So I need to give 1 unit of correction factor along with whatever food I'm taking, and the basal dose that I'm going to calculate according to insulin carb ratio. So that's how you combine both of them, and then you decide what's the pre-meal bolus dose is going to be. What is the acceptable value of sugar while managing decay?
Uh, obviously, when we are managing the decay, we need to bring down the glucose to a level where the acidosis has gone. So as usual, we say that less than 250, you need to continue with the insulin doses along with the glucose to manage that decay part. So once the child is out of the decay, then your acceptable levels changes when they are on subcutaneous doses. But when they are decay, you bring down them to a level somewhere around 200 or less than that, so that the child comes out of the decay completely.
So, how much time of insulin therapy and individuals, insulin carb ratio and conversion ratio becomes unique for that person?
No, see, it is always unique for each and every person. So that's what I said. The initial starting your ICR and ICF all can be the same, but 2 months down the line, their ICR and ICF can be totally different from what you have started. So it is actually unique for each and every child. It is never a fixed ratio, actually.
Right. And I think what Dr. Amit is asking is, I think uh, in my experience, insulin carb ratio and correction factor becomes settled around after concerted efforts of 2 to 3 months.
Yes,
Once they've settled for each child, they still continue to evolve because as they age, when they would hit puberty,
yes.
sometimes it also changes during seasons. If their playtime changes from morning to evening. So basically, it's a continuous iteration. But
Exam
after
time is
initial
completely
stabilization, you can easily kind of do those modifications on each visit.
yes.
Are there any standardized carb counting charts for North Indian diets?
I think
That's a
there
tough
are
one.
some, but then even one Metronics also give one carb counting chart. So, but I think you are anyway going to have a session on this carb counting, so I'm not going too much into that.
Okay. So let me tell you, there are two different there are 2 3 different resources. One is there is this NIN Hyderabad list which is there, which can be used for North Indian foods also. There is a paper by an Indian American in some, if I am able to find, I'll share it in the group. That's an extensive in which they've tried to compile this list. A lot of these apps also does Healthify Me and stuff like that. So they also have this North Indian food, this thing. Only problem with is that how to standardize those measures. Your katori, their katori is a different. So basically what you have to do is you have to use a kitchen scale, and then you have to actually weigh, and then you try and see how many gram of carbs are there. So those are the thing, but there is no per se standard carb counting charts for North Indian diets that is per se are available. Few resources that are there, I'll try and share it in the group itself. Okay, so Trasiba poor children pump. So I think we'll have to put a context to it. I'm not able to completely understand this question by Dr. Vikas. So, Dr. Vikas, if you can write it down in little detail, then we'll take it at the end of the session. Sir, if a child is doing ICR correctly, can they even consume sweets?
No. This is what I told, that we need to be understand that if you give a lot of simple carbs, there will be immediate surge, and then your insulin will not be able to cover that surge. So you need to avoid that. So even if the okay, if you are too mild enough to give your child the sweet, so what I tell them is even if they have to take the sweet, it has to be with their meal, so that at least there is a some amount of complex carb which is going, which will require some effort by the stomach to get digested. And in that process, even with this sweet, your blood glucose rise will be slower. So if at all they have to take, ideally it should not be, but if at all they have to, it should be with the meal. It cannot. So alone sweet, if you take, even if you are on the pump and you push the pump for the bolus, it will not take care of that sweet related rise in the blood glucose. So that's important, which we need to understand. So simple carbs, if you are taking, that will not be covered by any insulin.
Right. Yeah, absolutely. I think it should not be. I think diabetes, either type 1 or type 2, is like 50% is the discipline that we need to follow.
Exactly.
So it should not lead to assumption that now you can have sweets. But of course, if you are doing an ICR, then perhaps once in a while, if you take sugar during any party, during any function, you would be better equipped to handle that. So it should be that once in a while, perhaps ICR can be used to do that. but it should not lead to daily intake of sugar or to justify that. Okay. So then there is next question. Can you explain Dawn and Somgay phenomena and its significance? I think this is going to be there in the session on CGM and SMBG pattern. We've got doing a detailed discussion on this. So let's leave it for that session. And sir, in a case a type 1 diabetes skips dinner, should the basal dose still be given?
Yes, definitely yes. So dinner is the meal. So you may skip the prandial dose. If the child is not taking the dinner, you may skip the prandial dose. But basal you will not skip. Basal has to be there. So if you skip the prandial, you skip the basal. In the morning, you will find the child in the diabetic ketoacidosis. So don't skip the
Yes.
dose.
Right. So yeah, so we never miss the basal. Even if somebody doesn't take 3 meals in a day, you don't miss basal.
Yeah.
Even if you feel somebody's sugar values are going on the lower side, you may try and reduce basal a little bit on the lower side, but you still do never skip the basal. You give people to eat more, but then basal should never be skipped. That's your defense against DK. So we should not do that. How to manage a type 1 diabetes in a sick febrile state? What precautions should we take regarding to insulin therapy? I think, again, we've got a separate session on this.
Yes.
So we're not going to go into this because there is a session on medical emergencies in type 1 diabetes. So that's when we're going to discuss this sick day rules, as we call it.
Yes.
Okay, so any criteria to decide type of regular insulin and basal insulin? So do you do basal insulin? Do you give rapid acting insulin? When do you give fast acting insulin? Is there a way to decide? And also similarly, is there a way to decide which child can do well on NPH, which child can do well on glargine or dilute?
See, the ideal, if you ask me, ideal will be always to give a something like a degludec or glycine kind of insulin, which works for almost for the 24-hour plus as a basal insulin, because that is what is our requirement. And if we talk about the ultra fast rapid acting insulin will be much better because they are more acting like a physiological, can be given even the post meal. But see, ultimately it's depend upon the cost. So if somebody who's not able to afford, we definitely do manage with the regular and NPH insulin also. But yes, if somebody who can afford and can get a reimbursement, then I would definitely suggest that at least a glargine is the basic minimum which should be given along with the analogs insulin.
Right. I think so. These were the questions for today. I think there are the theme that I can judge is on honeymoon phase, and then a lot of these things are on ICR. So, and I think I let me tell you that this ICR thing is again going to come up in the session on carb counting. So we may have few practice there, and then we are also going to discuss this ICR thing during the session on CGM and SMBG again. So don't believe so that's when we are going to discuss them again. So over to Dr. Vipul Jain, please, sir.
Thank you, Rajiv. Thank you, Vineet, and thank you, Deep, for extensive session. I think this session is going to have a lot of views on YouTube where we are recording it. Amazing session. Thank you. And everyone will be waiting for the next session next Sunday, 11 a.m.